Next session, we have the Dr. Hayat Khan. Unfortunately, will not be able to be present with us because he has an urgent operation. Now we will move to Dr. Ashwan Yanathan has just make his talk. Now we will move to a very eminent professor, Professor Douglas Dunlop, one of the most eminent professors in Southampton. Professor Dunlop will speak about dual mobility cup in hip replacement. Professor Dunlop is a recorded presentation. It's with you. Professor Dunlop, you are with us, sir? Morning, Professor Dunlop.
Well, good morning.
Thank you so much for joining us again. Thank you so much. Professor Dunlop? Dr. Dunlop,
well, good
will
morning.
be
My name is Douglas Dunlop. I'm an orthopedic surgeon on the south coast of England. I've been asked to talk to you today about dual mobility total hip replacement. So this is where we work down here. We're a large teaching hospital, catchment area of about 3.6 million people. We do about 1,000 fracture neck of femur cases a year, 32 orthopedic surgeons. So I've been asked to talk to you today because of our experience with dual mobility. We were the first in the UK to use the implant, although it's been widely used for decades in France. Because we were the first, because we've used a lot in our fractured neck of femur patients, we've done more than anybody else, about 1,200 cases when we last looked in 2019, giving us about a 15-year experience. This was our first case in 2006. Challenging normally to deal with well-cemented dislocating total hip replacements in elderly patients, and I thought that a dual mobility, which is essentially a mirror finished shell bonded to the pelvis with a wobbly polyethylene head that clicks over the original head, would be a good solution. I'll also show you how it can be used as well as in frail elderly, how you can use it in fracture neck of femur patients, and also for cases of intrinsic instability. So here was that first case. We'd used a posterior lip augmentation device in the past to stabilize, but these don't work very well. And rather than digging out the implants, this changed what could have been a challenging revision into a fairly straightforward revision. Here you can see the proximal femur has very few abductors attached to it. And there's the final X-ray showing the cemented cup in situ. In the United Kingdom, the reason for revision total hip replacement has dislocation up there with aseptic loosening and infection as the primary three causes. And so instability is an issue. And many of you may think that increasing the head size, which orthopedic surgeons have done, if you follow the yellow line over the last 20 years, there has been an increasing use of increasing head sizes. But unfortunately, this has not translated to a reduction in the dislocation rate in total hip replacement surgery. The other thing that's happened in the United Kingdom is that there's been an increased interest in total hip replacement for fractured neck of femur patients, with patient advocates and elderly groups pushing for more use of the implant because of a better functional outcome. If you look at well, good morning. My name is Douglas Dunlop. I'm an orthopedic surgeon. The other thing that's happened in the United Kingdom is that there's been an increased interest in total hip replacement for fractured neck of femur patients, with patient advocates and elderly groups pushing for more use of the implant because of a better functional outcome. If you look at hip fractures, it is a high cause of disability in adults, and 60% of fractures will require some form of arthroplasty because more than 80% of those are displaced. And the incidence is increasing year on year. The usual choice is between a hemiarthroplasty or a total hip replacement. Often this is based on who the surgeon is going to be performing the surgery. there's a perception that it's cheaper to do a hemiarthroplasty with a lower revision rate, but at the expense of increased acetabular wear, leading to pain and a reduction in the level of independence and function. But actually, when you look at the health economics, after discharge, all things considered, total hip replacement is actually cheaper than hemiarthroplasty and fixation in the long run. The use of total hip replacement versus hemiarthroplasty is well supported in the literature. Here's a meta-analysis showing that perceptions that your mortality rate may be higher or your infection rate may be higher with total hip replacement is unfounded, and actually there is no difference, with the author's conclusion being that total hip replacement should be offered to patients with displaced fracture neck of femurs if they have a reasonable chance of surviving at least 5 years. In the United Kingdom, we have the National Institute of Clinical Excellence, which has suggested that patients who are able to walk independently out of doors, are not cognitively impaired, and who have an ASA of 1, 2, or 3 would be medically suitable for the procedure. Certainly in Southampton, the increase in use started about 2009, when we used it for the majority of fractured neck of femur patients, with about 120 or so patients a year having this performed, giving us a fairly good database. I'll show you the first 628 in a minute. When you're planning revisional surgery, it's a good idea to have a look at factors that can increase the instability risk, such as resecting bone, resecting soft tissues for infection or fixation, fixation of pelvic discontinuity, or if you're unlucky to have a metal on metal. I'll just move a metal on metal situation, then it can be challenging. And the use of constraint or dual mobility is certainly something to be considered. Other things to consider with our fractured neck of femur patients, we tend to use a muscle sparing approach, which will improve stability as well. So looking at the first 5 years of our usage, that's 236 patients. 78 of those patients, it was used for revisions. Just over half, 126, it was for fractures, and then 32, a mixed bag of others, which I'll show you. So of the 78 revisions, you can see that instability was the primary cause, with a few adverse reactions to metal debris and periprosthetic fractures, etc., filling in too. In the non-fracture related cases, a lot of them were for inherent instability, such as oncological resection, or neurological conditions such as cerebral palsy or Parkinson's disease, which might destabilize the hip. And in the fracture related, the vast majority were neck of femur or failed neck of femur treatment. So of those 236 patients, the vast majority, or 222, had an increased risk of instability. We followed them up 2 years minimum for total hips, a year minimum if we could for fractured neck of femurs, and the majority of the revisions for more than 2 years, which gave us a dislocation rate of 1.3%, or 3 of the cases, which compared to the literature in that group would normally give you at least 20 to 30 patients who would have dislocated. So massive advantage for us. So of those 628 fractured neck of femur patients, this is our first 500 that we were able to follow up with adequate data. And I'll just show those to you as well. Here's the broad brush outcomes. Vast majority were female, elderly, with a significant length of stay. And I'll just draw your attention to the ASA. A significant number were ASA 3s, even some 4s. The 1 year mortality rate at 5%, and a dislocation rate 6 patients, or 1.2%, which is amazing for that group of patients. Of those 6 patients, 3 were able to be reduced to closed. 1 was actually aware of the polyethylene giving an internal late dislocation, and 2 of them were difficult to relocate closed and had to be opened. That's usually because the large polyethylene head gets stuck in the sciatic notch, or I'll show you at the end how the soft tissues have a role to play. So the literature's found very similar experience to us. If you look at total hip replacement there's about a 6 times reduction in dislocation rate using dual mobility. And for hemiarthroplasty, about a 3 times reduction in dislocation rate using dual mobility. There's lots of different designs out there. There can be self-centering, ones with cutaways or raised shoulders. They obviously can be cemented or uncemented. The head size can be different, and the polyethylene can be cross-linked or not. Certainly the French experience is that if you're doing it in patients under 70, you probably shouldn't be using standard polyethylene because of the internal dislocation and wear rate. These are some of the design differences. Monoblock obviously with cemented or uncemented, and modular with the option of screws, giving you that improved fixation if required, but at the disadvantage of increasing the wall thickness, which will then reduce the jump distance and the size of the polyethylene and increase the cost. It also more recently has possibly been associated with problems at the interface between the shiny insert and the modular shell. Here you can see some other designs such as a raised shoulder on the implant. So you can use it when you're doing difficult, challenging revision cases, either with augments, shells, or cages, where you put the shell where the bone is, and then you can cement the dual mobility in the orientation that you wish. Extending the indication can be used as well, very rarely. We have a lot of large bearing metal and metal total hip replacements and hip resurfacings. And as these patients age, it may be preferable just to do a simple femoral revision without digging out the cup, which is particularly the case in dysplastic patients where there may be little remaining bone stock. The implant choice, here's just a bunch of 4 different manufacturers showing you the different sizes of polyethylene with the same size of outer diameter of the shell. So the jump distance will be slightly different depending on the manufacturer. But in our hands, it certainly has been a very welcome solution. There's some challenging cases that we've dealt with. Here's an oncological resection. Patient had been back and forth many times with recurrent dislocations. Many years ago, we did a dual mobility, and the patient is still alive and has not been back with a further dislocation. As an adjunct, if you are doing a proximal femoral resection, we found it helpful to use an aortic graft sleeve around the implant, which you can then suture the soft tissues to. And other things that you can do, particularly if you've poisoned the area with a large bearing metal on metal with Alval, then you need to fill the dead space and improve the blood supply to the bone with a flip back vascularized graft. I've done quite a few 3D custom revisions, 21, all of which we've used dual mobility. We've had some nerve palsies, a couple, but no dislocations so far, touch wood. Here's a case, you can see there's very little in the way of abductors there, and the implant isn't actually in the femur. Here you can see the x-rays post-operatively of the implant. So challenging with poor abductors, but stable. And my theory is that if you can keep it in joint for the first 3 to 6 months, then actually the soft tissues will grow around the neck, form a sort of scarf or collar, and make it stable in the longer term. So next time you see one of these, don't reach for the Oscar or the cement removal kit for the femur. You can, if it has a modular head, put on a polyethylene head like on the left, or if it's a monoblock, you can use this. Just keep your finger on it so it doesn't ping across the theatre. And here you can see just a quick video of the cementing of the cup into the old cement mantle in this situation. And that's the end of my talk. Very satisfying experience in our hands. Thank you.
Thank you so much, Professor Douglas Dunlop from Southampton. Professor Dunlop talk is a recorded talk. I'm sorry, he's now in the outpatient clinic, so we will not be able to receive questions. Our last speaker in this session will be Professor Khaled Hamid Salim, will speak from UK. Professor Khaled will speak about bearing surfaces in hip arthroplasty.
Thank you, Dr. Muhammad. Actually, I'm practicing in Germany since several years, but I'm professor in Cairo University. My topic today is bearing surfaces in joint replacement. What is the definition of a bearing surface? It is the area of contact between two adjacent objects, and in arthroplasty is the articulating surfaces. Osteoarthritis is per definition a problem of the bearing surfaces. And to treat it right, we have to choose an ideal bearing surface to substitute the destroyed articular cartilage. What is the characteristics of an ideal bearing surface? It should offer good tribological properties, low friction coefficient, less wear and less particles. It should permit adequate lubrication and should be resistant for third body wear. It should always also do low tissue reaction and should be machinable so that the industry can offer this structure for us. And the aim is to have a good longevity of the prosthesis. And being Egyptian, we are proud that the first recorded tribologist in history was the worker that were transporting the statue of T from the tomb at Saqqara 2,400 years before Christus. The pioneers of total hip arthroplasty were all British. Peter Wiles in Middlesex in England did the first total hip replacement in 1938. He performed it metal in metal. It was like a DHS with a prosthetic end made of stainless steel. And then McKee developed a metal-on-metal Vitalium prosthesis that was cementless. And following the invention of polymethyl methacrylate, McKee and Watson-Farrar developed the cemented metal-on-metal McKee-Farrar prosthesis in 1960s. And it was the first widely used total hip replacement. Ring provided the next milestone in the development of total hip arthroplasty. He distrusted bone cement, and he developed a self-locking uncemented metal-on-metal prosthesis in 1960s and 1970s. Sir John Shanley did his first attempt at total hip arthroplasty using Teflon on Teflon in the 1950s. And his next attempt was metal on Teflon, but both structures failed catastrophically because of early osteolysis and loosening, and because of the wear particles of Teflon. So he noted that also that the larger femoral heads caused increased wear. So he decided to use small heads in order to decrease friction. So in 1962, Shanley began his third attempt with a cemented femoral prosthesis and a small head, 22.25 millimeter, stainless steel head on a ultra high molecular weight polyethylene. And this was the most successful at that time and proved to be the model for all subsequent total hip arthroplasties. His work on friction marked the end of the era of metal on metal, so that after having three types of prostheses, the McKee-Farrar, the Shanley, and Ring types, only Shanley implants survived the end of the 1970s. So what options do we have for arthroplasty in total hip or in total knee replacement? Either hard on soft, as we all know, or hard on hard. Hard on soft is metal on polyethylene or ceramic on polyethylene. Hard on hard is metal on metal or ceramic on ceramic. So the polyethylene, this was the idea of John Shanley. It was his low friction arthroplasty. Metal head against a polyethylene insert. It offered a survivorship of 80% after 20 years, and the linear wear was 0.1 or 0.2 millimeter per year. But even this 0.1 millimeter is enough to cause millions of particles that may end in osteolysis and loosening. So that it was a problem in young patients, and the innovation was to provide the best wear reduction and the least amount of wear particles. Using irradiation in order to sterilize polyethylene, it resulted in heat treatment and the formation of highly cross-linked polyethylene with no measurable wear under in vitro conditions. And this highly cross-linked polyethylene was a great invention, and it started in total hip arthroplasty in Western countries in 1990 and in total knee arthroplasty in 2001. And nowadays we have several companies, each with its own highly cross-linked polyethylene. I actually used this from Smith & Nephew XLPE. However, this cross-linking improves the wear resistance, but at the price of mechanical properties. Why? Because the cross-linking leads to the formation of free oxygen radicals that can cause oxidative degradation of polyethylene. This can lead to catastrophic failure, especially in total knee replacement, And the solution is now using it with treated vitamin E polyethylene, because tocopherol is an antioxidant, so it grabs these oxygen radicals. These are the milestones in polyethylene manufacturing, from traditional polyethylene up to vitamin E stabilized polyethylene. Back to metal on metal, we have seen that we started actually in total hip replacement with metal on metal prosthesis, and several years later, the survivorship of the early McKee-Farrar prosthesis led to a revival of metal on metal arthroplasty. And it had been shown that the problem was in the machinability and not in the frictional wear, so that we had in the 2000 year a revival of total second generation metal on metal arthroplasty. And by the year of 2006, where there were 18 different models, they offer a good early result, but the midterm results were problematic because of the systemic and local metal debris. Systemic reactions, the cobalt and chrome ions were deposited in the reticuloendothelial system. They can cause cytotoxicity or cardiomyopathy or even neurotoxicity. And there was concerns about carcinogenicity or tetragenicity of the cobalt and chrome ions because they are able to disrupt DNA particles. And locally, it was not much better. We had a lot of cases with hypersensitivity reactions, with alval lesions, aseptic lymphocyte-dominated vasculitis associated lesions, pseudotumor formation, and even metallosis. Metallosis is a metal-induced synovitis with bone destruction. It is caused by the friction of two metal surfaces, resulting in metal ions that trigger a chronic inflammatory response ending in bone and joint destruction. It is rare in knee arthroplasty. It is more in hip arthroplasty metal on metal, but I was able to revise 3 cases in Germany with this metal on metal contact because of highly destroyed polyethylene, even with a fracture of the tibial tray. You can see here this bubble sign or cloud sign with metal debris. So this was the revision done for these cases, or one of these cases. And intraoperatively, you can see with metallosis, severe soft tissue destruction. The joint is full of this black stained secretion that is like the used car oil. And you can just remove the bone like with a curette, and you may sometimes end with a tumor prosthesis. These are the slides of this case. This is on the left side, the normal synovium, on the right side, the metal-induced synovitis. And I was able to publish this in the Journal of Clinical Orthopedics and Trauma last year. So ceramics, they are either oxides, aluminum oxide or zirconium oxide, or non-oxides like nitrides and carbides. Ceramics offer a very low friction, very low wear on polyethylene. They are very highly wear resistant, and their particles are less biologically active or even biologically inert. The introduction of ceramics was in France by Boutin in 1970 and in Germany by Mittelmeier in 1974. Second generation Biolux implants are now rarely used. Third generation Biolux Forta and Biolux Delta are now in common use. They are a German invention in a company in South Germany in Blochingen. Ceramic on ceramic offers extreme hardness, exact sphericity, superior surface smoothness, optimal clearance, scratch resistance, no third body weight, and excellent biological behavior. The problems with old designs like squeaking, it is a problem of lubrication, but sometimes it needs revision. Ceramic breakage in old designs or by heavy patients, and not to forget, ceramic heads are not to be used on used taper in revision total hip arthroplasty. Oxenium is a zirconium with 2.5 niobium metal alloy, and its surface got wrapped with oxygen and to form zirconium oxide, which is a true ceramic. So it is not a layer or a coating for this femoral head. It is actually the structure that has a ceramic surface, and it's actually my favorite femoral head. It offers no risk of ceramic-like chipping or squeaking. It is hypoallergic for patients with metal allergy. There is no nickel, cobalt, or chrome in it, and it has a reduced risk, a really reduced risk of osteolytic potential. The indications we use, oxenium heads for all patients, but it is a little bit expensive, so you can reserve it for young patients or for cases with use taper. Like I said, you are not allowed to use ceramic heads. What about the knee? Metal on polyethylene is still the gold standard, cobalt chrome femoral shield on a ultra-high molecular weight polyethylene. And conventional ultra-high molecular weight polyethylene does better than cross-linked polyethylene because of the oxidative degradation, like I said before. What to do in young patients or in patients with metal allergy against nickel or cobalt chrome? You can use ceramic implants. This is rare. Or you can use oxenium implants with this black oxenium femoral shield. Or you can use titanium nitride coated implants like the gold prosthesis on the right from Escolab. So to summarize, ceramic on polyethylene represents most total hip arthroplasty performance nowadays. And metal on polyethylene represents most total knee arthroplasty performance nowadays. Use cross-linked polyethylene in total hip arthroplasty, but use conventional polyethylene in total knee arthroplasty. Consider ceramic on ceramic or oxenium in total hip arthroplasty in young patients, and consider oxenium or nitride-coated total knee arthroplasty in young patients or patients with metal allergy. And don't forget the ceramic pitfalls in revision total knee arthroplasty. Thank you very much.
Thank you so much, Professor Khaled, for this marvelous talk, sir. Thank you so much, sir.
Thank you.
If we have any questions to Professor Khaled?
Just one question, Professor Ashraf, if you please. Regarding the using ceramic in use taper, we can use ceramic if we use the metal jacket. You can do this, or you don't like to use this?
All ceramic is not allowed, but there's a lot of companies that are now making a cone inside
the metal jacket. Yeah,
exactly. Yeah.
So you don't prefer to use it even with this?
You have the taper should be metal. So, but ceramic outer surface is exactly okay.
Okay, that's one. Thank you.
Any other questions, sir? Okay, thank you so much, Professor Khaled. Now we come to the end of this session. لو تسمحوا لي حضراتكم بكلمة واحدة في نهاية السيشن. أنا بقالي 45 يوم بجهز السيشن دي. اتصلت بكل البروفيسورز من كل الناشوناليتيز اللي كانوا معانا في الكورس. معظمهم رحبوا ترحيب شديد. أنا يعني في نهاية السيشن دي بشكر جمعية جراحة العظام المصرية والبورد المحترم بتاعها اللي لولا السبورت اللي ادهولي في الكورس ما كانش ممكن ابدا ان انا اجمع كل الناشوناليتيز دي in such one webinar and in such one day. فانا بشكر جمعيه جراحه العظام المصريه واساتذتنا المحترمين كلهم في البورد بتاعها، والحمد والفضل والشكر لله سبحانه وتعالى اولا واخيرا. شكرا لحضراتكم يا اساتذتي.